Dr. Casamassimo is board certified in pediatric dentistry and is an attending dentist at Nationwide Children's Hospital, where he served as president of the medical staff in 1999. He is professor emeritus at The Ohio State University in Columbus, Ohio, a past president of the Ohio Dental Association, and currently chief policy officer of the American Academy of Pediatric Dentistry in Chicago, Illinois. Dr. Casamassimo currently serves the Ohio State Medicaid program as a policy consultant and has authored or edited over 500 publications in the areas of pediatric dentistry, care of persons with special health care needs, and dental education. More recently, he represented AAPD on the Healthy Eating Research Project to develop national guidelines on beverage consumption in children 0 to 5 years old. The recipient of numerous awards, Dr. Casamassimo's interests include oral health of children and adults with special health care needs, health services research, and oral health disparity. Please help me welcome Dr. Casamassimo.
Great. Well, thank you for that very generous introduction. I am going to talk about diet and nutrition as it relates to pediatric dentistry, and hopefully will give you some ideas. I'd like to say I'm giving you a cookbook, but I'm really giving you a menu, hopefully by the end of this talk, on things that you can consider and weave into your nutrition counseling for children. If you're a dental professional or a non-dental professional who wants to address some of the issues related to oral health and disease as it relates to nutrition, primarily dental caries. So, good nutrition really should benefit both systemic and oral health. And usually those recommendations are synchronous and bring both of those to bear when we counsel our patients. But we really have to understand how they all interrelate. So hopefully by the end of this presentation, some of that will be a little clearer. Next slide. So I'm not going to belabor this because I had a nice introduction. The last two things, though, that I would point out are that I probably don't look that good right now, but I have worked with kids and special needs patients for 40 years and dealt with a lot of nutritional issues related to systemic health and to oral health in that population. So I feel comfortable giving you the information that I'm doing today. And I also, like many of you, I'm sure, now work with a much more diverse patient population with cultural imperatives and health differences and considerations that are different than they were 20, 30 years ago. So our challenges are out there for us. And so hopefully I can talk about some of those and maybe not answer every question, but at least give you some directions on ways to pursue those. So next slide. So this is what I'd like to do today. I'm going to talk about a paradigm for oral health related to nutrition and particularly dental caries that still are showcase disease, if I want to use that terminology, and then talk a little bit about the diets of the most vulnerable in terms of dental caries in the populations that we care for. I participated in the beverage recommendation process a couple years ago for kids under 5. So I'm going to talk about that and dietary recommendations. What I think is good advice from a dental perspective, and then try to wrap it all up in a counseling framework and take any questions that you all may have. So hopefully you'll leave with an understanding of what the limitations are of a it's hard to say, mouth-based nutritional counseling for high-risk populations that still it's very prevalent in the dental community, in the dental professions. We still tend to focus on the mouth rather than the big picture that you'll see. I'll try to propose. Look at your current dietary approaches and consider broadening those to take in the characteristics of your patients and their particular individual needs. That, you know, we're in an era of personal health care and okay. And so this, you know, we really want to talk more about how we can address individual patients. Look at the competing and synergistic aspects of both of nutrition for oral health and systemic health, and both good and bad nutrition, things that are happening in our patient population. Look, I'm going to start out by talking about diet and overall caries risk. And I want to talk a lot about, not a lot, but it's a significant amount about caries risk, because I think there are some misconceptions about that science. And then the last thing is, hopefully you'll leave with just one thing that you might want to change to make your counseling related to nutrition and oral health a little more focused and effective. Next slide. So I would just caution you to say that this is a big area. It may seem like it's pretty simple: bacteria, teeth, substrate, and those three things, when they're combined, cause dental caries. But hopefully, by the end of this presentation, you'll see that it's a lot more complex, and there are many facets to diet as relates to oral health. So next slide. First thing I would say is find a good nutrition professional. Maybe some of you on this call are those people. I've had the good fortune of working with some really good nutrition professionals. I've done some work with barometric surgeons and pediatricians who work with children with feeding disorders, psychologists, looking at diet and its effect on weight and oral health, caseworkers who really are the frontline people in trying to get some of this stuff done, and many others who know far more about the role of diet and nutrition than I do. And I would encourage all of you to have someone on your list of fellow professionals who you can consult on issues related to diet, because as you'll see, some of them can be pretty complex, particularly when they relate to medical issues. So if you're one of these people, I showed on the right-hand side of the slide, I've worked with Katrina Holt. Some of you may know her name or know her, who for 30 or 40 years almost, and other people who are very good in terms of their knowledge of oral health and nutrition. Teresa Marshall at the University of Iowa is another tremendous resource. You can look up her literature and publications as well. So find yourself one. It'll really benefit you in the long run. Next slide. So I'm going to start out by talking about caries risk. And for the dental professionals in this webinar, I think we all have our thoughts about caries risk. Some of us use things like Canberra, very sophisticated and validated tool. But there's a lot that we really don't know about caries risk and caries risk assessment. It really is, as it says in number 1, still a very crude science, and you may get a score depending on the tool that you use, but it's really more of a maybe, or an arrow on a dial that's pointing toward caries as opposed to all the way over. So it's not, as much as we think and we've tried to make it a very sophisticated science, it remains a crude science. For example, we have very little idea how risk factors prioritize. So we have things like lack of fluoride, diet, oral hygiene, and we really don't know which of those is the most important? I think my suspicion is diet is probably the most important, but where does fluoride lie in that? And if you take one away, one of those risk factors away, do others fill in their gap, or does it inactivate those others? Or we really don't know that. And so we essentially take them all on and try and reduce those risk factors. But as you can see, it's a very, very crude science. Nutrition and its importance in imparting protection is less well understood in terms of how good nutrition protects someone from dental caries, with the exception of sugar, that we know that pretty well. We're really even still not sure how fluoride works. We think it's a topical effect, but right now it's we have so much fluoride and kids still get tooth decay. So even that area has some work to be done. We don't know. I'll speak for myself. What I do with a score. If you're an 80 out of 100, what do I do? If you're a 60 out of 100, what do I do? We really don't know what to do with those numbers. And then the presence of caries, which was the first real caries risk factor that was found to be 100% valid. If you had caries, that meant you get caries. And then time, how much time, how old are you, how long have those teeth been in the mouth? Those seem to be the strongest ones, but again, we don't know how to quantify those. Next slide. So let's talk about caries risk and begin to move into nutrition. So this on the right is I call it the Fisher-Owens diagram. Susan Fisher-Owens is a pediatrician in California who has spent a lot of her career looking at oral health issues. And she and some colleagues put together this design building upon the Kai's diagram, which is that three-ring sign at the very bottom. And the three-ring sign, as most of you know, is when you have a host or a susceptible tooth and you have the right bacteria and you feed those bacteria sugar or carbohydrate, you get caries. This diagram of caries initiation said, it's not so simple as that, because in everyone's experience, maybe those of you listening to me, you have kids that have all three of those factors overlapping and don't get tooth decay. And then you have others who seemingly do remove the microflora every day, 3 times a day with a toothbrush, and use fluoridated toothpaste and still get tooth decay. So it's not simple. And what Susan did is she and her colleagues said, well, there are other influences besides what happens at the tooth surface. And so you see child level influences, other things related to the child. I'll talk about some of those, like the systemic disease. Family level influences, things like cultural imperatives and diets, and then community level influences like fluoridated water. So you really, to do any type of risk factor intervention, and this is going toward nutrition, is you have to look at the patient, or the mouth, the patient, the family, and the community. So if we focus only on the mouth, we're really going to miss the boat. We're going to miss probably a factor that's staring us in the face if we really don't pursue that further. So we're going to talk about things like food deserts, cultural values, cultural diets, food preservation capability, income, and a bunch of other things that will hopefully make the counseling that you do more effective. So next slide. So the reason for this, and this, if you want to, on your way home, driving home, is, is this a chicken or an egg, or is it a chicken or egg phenomenon? In other words, does poverty drive diet to support dental caries? Or when you have dental caries, does that inability to eat and to process certain foods and ingest certain foods increase cariogenicity? So it's we don't really know. But these two graphs here on the lower left, the first one, that the set of four curves that's a classic one. I've in my research for this presentation, I saw it being used several times by different authors, and it essentially shows the consumer price index, which is the second curve from the top, and then it shows the cost of fresh fruit and vegetables, which is unattainable for many families, but then the ease of sugar and other things, and then carbonated beverages. So that's well within the price range of many families. So they choose those rather than fresh fruits and vegetables. The other thing, the next center graph talks about how sugar has penetrated our diet, and particularly in terms of sugar sweetened beverages. And I'll talk more about that as we go through the presentation. But you can see over time, and this stops at 2000, but this curve has continued, may have leveled off a little bit, but it's still, sugar sweetened beverages are a tremendous part of our diet. So what comes first, the chicken or the egg, and do they feed on one another as a child grows older? We don't know. Next slide. So this may be new to some. If any of you are in education, you may have seen some of the work of Ruby Payne. It's kind of blocked out in my screen here, but she was an educational psychologist, and tried to put into perspective some of the differences in the kids who are in our schools, kids who come from poverty, kids who come from the middle class, and kids who come from wealthy families. And so I highlighted the areas that are relevant to diet of her work. You have an opportunity to read some of it. It's fascinating. So, if you look at that top level and apply it to diet, survival in many cases is the driving factor for those in poverty. Whereas in the wealthy population, there are things that are social and political advancement, and middle class are focused on a whole different set of values. Look at world is local, the world is national, the world is international. Very often for those in poverty, it's a very small world. It's the block. It's the location in the city where they get their food, where they get their social interaction, where they can take solace and comfort. And then related specifically to food, and Ruby addressed that, is if you're poor, am I going to have a meal for me and for my family? And so quantity is the primary driver as opposed to quality. And if you have enough money and access to food, it's how it looks becomes important. So I think this is very important to put in the context of nutritional counseling, is to really understand your patient. And this is not to generalize or to pigeonhole people, because you really shouldn't do that. And as we're learning about social determinants of health, we have a lot of resilient people who we may just stereotype as being in need, when in fact they're survivors and they've done very well. So point is, consider these things, but don't necessarily make them drivers. Next slide. So before we go any further, nutritional counseling in dentistry and for oral health is not easy. And hopefully, if you leave with nothing else at the end of my presentation, you'll agree with me that, whoa, I didn't think about all those things. Or, well, gee, that one factor that I had never considered really was the turning point for me making some headway with this family and this child. So if you think you're going to leave here with a cookbook, again, it's not what's going to happen. I'm giving you a menu, and hopefully you can adjust that menu to fit the patient who's looking at you for help today. Next slide. So I'm going to focus on preschoolers because we could talk about the elderly, we could talk about the adult, we could talk about teenagers. The preschooler, for a number of reasons, they have more teeth than babies, so they're, that you're talking about in many cases full primary dentition. Dietary control still remains at home. They're not out in school. They're not necessarily with pocket money and ability to control their own diets. They're just at the point of beginning their out of home life. So there's those options or risks, if you want to use that terminology, like daycare or preschool or Head Start or things like that, are still limited. They're near their first dental visit. They should have had their first dental visit, but the reality is today they're probably going to be getting their first dental visit. They eat solid foods. There are some guidelines available for this population. We'll talk about those later on. Their beverage guidelines. And then in this population, one of the areas that has consistently frustrated dentistry is untreated caries continues to be a problem in the preschool population. We have not been able to stop that. We've had reductions later on in life, but we still have to admit that we haven't been able to solve the problem with preschool kids. So that's why I'm going to focus on that group. Next slide. So think back on that diagram from Susan Fisher Owens, and let's talk about, I'm not going to talk about the mouth. I think everybody who is a dental professional on here, has some dental experience, can deal with the 3-ring sign and doing some very gross interventions on those risk factors. So I'm going to start with the child. Some of the things that we have to take in consideration is the child's age. What is their diet? What are their nutritional needs? What are their growth and development requirements? They need to have a certain number of calories, a certain amount of protein. Those are things that we need to look at and consider. They're getting food preferences. So last night, my wife and I took care of our 2 very young grandsons, and apparently the older one, who's 5, survives mainly on the McDonald's chicken nuggets and mac and cheese. So who knows? Kids have their food preferences. Where do they get their food? That's another thing that they're limited. They can't pick their own food, so they really get it from their parents or from their caretakers or from agencies or programs that they're in. What are their medical issues? I'll give you an example. One of the illustrations I'll try to use is a kid that I saw many, many years ago who had some special healthcare needs. What's their oral health status? Remember the picture I showed you earlier on with the kid with a mouthful of tooth decay who can't consume hot, cold, or sugar because it makes their teeth hurt. So what do they eat? And then what are their daily activities? How many hits are there possible with sugar sweetened foods, beverages, or sugar containing foods in the course of a child's life? So those are the child-based considerations, kinds of questions that you should be asking families when they sit down with you. Next slide. So here's the questions. Is the water fluoridated? And we have to talk about beverages and fluoride adequacy. Are they getting enough fluoridated water? Do we need to use supplements? Again, this, you can see, it becomes very complicated and it requires a lot of questioning and solution finding. Does your child sleep with a bottle? Provide alternatives, and I'll talk about some of that later on. We've had a lot of those things pulled out from under us by the new beverage guidelines. Does your child snack? Do a sugar assessment. That's a very simple dietary check that we can use with kids, and it really has some benefit. Does your child have access to sugar drinks during the day? The big one with the preschooler toddler is the walking bottle. carrying that bottle of some kind of liquid with them wherever they go, availability of sippy cups, resealable bottles, and then something you may have to eyeball parents about is their own modeling of them having the same drink. We see that every day in our clinical care, parents walking in with a resealable bottle with sugar-containing liquids. Looking at the overall diet, fresh foods, processed foods, meal, do they sit down for meals? Do they get food right before bed? And you may have to do a diet history, the old traditional diet history for some families to get the information. Is the child out of the home for care? Remember, we talked about this is the time where they begin preschool, Head Start. What do you know about those programs? What does the parent know about those programs in the food that their child gets? And then can kids have access to food? Can they go to the refrigerator whenever they want to? Do they know where sugar sweetened things are stored? Or do they have a cookie jar in the old parlance? So those are that's on your child diagnostic, and those are the kinds of questions that you would be asking families when you see a child. Next slide. So let's talk about family considerations, because that's the next outer circle in this diagram. How does the family function? Are there any religious and cultural imperatives that you have to deal with? Can the family store food and prepare food? What is the caretaker's knowledge? What's their health literacy related to diet, particularly related to diet and dental caries? Do they have facilities? They have an oven? They have a stove that functions, or is everything a microwave? And then what are the competing needs within that family? I mean, food is important, obviously, but there's rent, there's heat, there's transportation. There are a lot of competing things that may limit your options. Next slide. So again, here's your list of questions. What is the family constellation? Are there cultural issues directing diet? So it's, we have 140 different types of interpreters at our hospital. And so if you say there are 140 then plus cultural diets, then, I don't know what those are, and maybe you do, but I think you really have to find out what a kid eats and when they eat. What is their health coverage? Do they have good insurance? Can they get information? Can you get information about what kinds of services they can get? Can they come in for multiple recalls to allow you to check how effective they are in dealing with your recommendations? The family cook, we talked about that. Is there a refrigerator, or do they depend on refined processed foods that can sit on a shelf, for months? And that's that's the primary part of their diet, pastas, for example. Diet during the day. So you may find out that they're at home a very short part of the day and only with one parent, or with grandparents. Is obesity an issue? That may require that you work with a primary care physician or someone else to deal with their diet, and you have some input and work together to try to design how your recommendations fit in with theirs. And then food assistance. The many families, and particularly in this inflationary period that we're in, I just heard on the news last night, families pay $500 more a month for food on average than they did before this inflationary period. And that's, for many families, that's impossible. So they go to food banks, which may be a good thing because they get some choices they wouldn't have otherwise. What do food stamps provide? Do they get WIC counseling? So I think you can see, hopefully I'll stop here for a second before I move to the next orbit affecting oral health and diet, and just see this is not simple. This will require some talking, and you may find the magic bullet in there somewhere, or you may find out that's an overwhelming set of circumstances that you have to deal with. Next slide. Okay, let's move on to the community. And I hope everybody's seeing that we've moved from the mouth to the child to the family. Now we're talking about the communities. These are all factors that impact on oral health and dental caries in our patients. So you've all heard about food deserts, in many places, in rural areas, urban areas, you have parents or families have to travel 30 miles to go to a decent sized store to have food choices. And so many families rely on convenience stores. And I had a discussion yesterday with our state health plan group of many different disciplines, education, nutrition, dentistry, dental hygiene, about food deserts and the fact that more and more convenience stores now have fresh food because they're filling a need. It's kind of an interesting discussion. You have to deal with marketing by big stores. This is on sale. You can buy one case of Coke, and I don't mean to disparage Coke, but sugar sweetened beverage, and you get another one at half price. Limited food choices in convenience stores. Reliance on family on school lunches. That if you're like me, to realize that when one of the unseen effects of the COVID pandemic and the closing of schools was the effect on nutrition of children. Significant. Cultural and religious patterns. The use of food pantries, we talked about that. The availability of food pantries. So our biggest one is probably from where I live in central Columbus, is probably about 10 miles. So a family would have to get there to be able to take advantage of that. Transportation has a tremendous effect on all aspects of our life. And so in a rural area, there may be no public transportation. That's a big issue in access to care and also to access to adequate nutrition. Climate, we may assume that everybody has air conditioning, but that's not true. So you have some hot homes and kids sweating and drinking more to stay hydrated, and what they drink can be a factor. And then we talked about rurality. So you can see all these different factors can feed into things that have an impact on diet and nutrition, and that nutrition as it affects oral health. I just noticed on the right, you see that Kellogg's split. They now have a sole industry that is focused on snacking. And honestly, I don't think that's a good thing. And as I look in Tony's mouth, I don't see any teeth. So he may have been eating too many Frosted Flakes, but that's another story. Next slide. So here's your checklist for the community. Family live in a food desert. Our nutrition resources, meaning counselors, WIC, those kinds of things available to them. Is community water fluoridated? That's another big issue. We talked about that yesterday in our state group. If you live in Flint, Michigan, that made national news. You don't drink the city water. You don't turn on the tap. You drink bottled water, and a lot of bottled water doesn't have fluoride. So these are, there's some things we took for granted, really have to be talked about in our nutrition counseling. Is there communal support for good nutrition, or does everybody eat the same stuff and have the same problems? What is school nutrition status? What is in the meals there? It'd probably be worth your while. I'll talk about this in a second here. Talk to the school nurses or the school administration about what's available in their meals, so and you can talk to parents about it knowingly what is available for their child. Does the child see a physician, primary medical care, and that nutrition is addressed in that, and you should be in concert with what that is telling the families. And then what's in the daily environment? Is there AC? Is it always hot? Is it always cold? What is the availability of fluids? And those kinds of things. So a lot of really essential questions that you have to ask based on the community and system that the family and child live in. Next slide. So this is just a summary. I'm not going to go through this slide, but you can see this little guy. These are all the questions, or not all the questions, but this question areas that you would probably have to cover if this child presented and you wanted to do an adequate assessment of their diet. This is quite a list. And the things I talked about up until this slide, you can see that there's just a tremendous amount to be covered. Ideally a child, if they have no tooth decay and they seem to be doing the right things on a very gross level, you may be able to skip a lot of this, but you may not be. If a child has caries, you really got to get down to the nitty gritty and try to figure out what's going on. Next slide. So this is the little guy I talked about earlier. He was a patient of mine many, many years ago. And so he has special needs. He's fed with a G-tube, which means that very little goes by mouth. He has selective oral feeding with the idea of trying to develop his ability to take food by mouth for its psychological and nutritional benefits, and minimization of the amount of compliance that's required by the family. He has limited dexterity, so his ability to do hygiene is not great. He takes centrally acting medications, so his salivary flow is affected. So that's going to be a factor. And then because of his G-tube, he has calculus accumulations on his teeth that have to be dealt with. In his case, we put him on an anti-tartar toothpaste, and it reduced his accumulations dramatically. So that was easy. If you move up to the family, he has compliant parents. They care for this little guy, do everything they can. They know him. They know his needs, his abilities, and so on. He has no siblings right now, so he gets all their attention, and they have very good insurance coverage. At the community level, access to water fluoridation, and a lot of the food that he consumes is mixed with fluoridated water, so we know we're getting some benefit systemically and some off in the saliva. He gets good transportation to dental visits. They do some brushing at school. And so those are all positives. And at the systems level, he gets comprehensive care at a major medical center. So good nutritional counseling is available. And his dentist, who was, in this case was me, was able to work with the nutrition specialists at the hospital and make sure that we were all doing the right things together in the right way. So this is just one example of how a relatively easy one to say, how do we apply all of these orbits of effect for a patient's benefit? So he came up with an individualized plan, and he did very well. Next slide. So some advice, we'll start here. Know your patients and your community. If you work in an FQHC or in a practice, in a hospital, in some other fixed facility that serves a relatively consistent set of patients with characteristics, know income levels, know who's coming to see you and what their abilities are and their limitations, know the cultural norms that they adhere to, things that affect their diet, know their backgrounds, where did they come from. There's a great article I came across years ago about immigrants to Salt Lake City from Central and Central America and Mexico, and they don't drink the water there, just like they tell us not to drink the water because it has bacteria, it can cause illness, and so they drink bottled water. So we have a population, a very poor population, who does not drink communal water, and I would never have guessed that. So what community services are available, what the school systems are, where you are, what the Head Start programs that are available for the kids. And again, we're focusing on preschool kids right now. So know your patients in your community and what the resources are, because one of the things we're learning now is that we are a village. If you're a dental professional or a nutrition professional, you really have to stick your nose in other professionals' businesses for the benefit of your patients. Next slide. Okay, so moving on to counseling, and again, go back to the two slides the one that showed the universe, that this is very, very complicated, and then be willing to accept small successes. So sugar and water fluoridation remain key protective elements, and what's the word I'm looking for? Negative elements, respectively. Those are still the primary ones. And as you saw, or hopefully saw, those two elements extend from the child to the family, into the community and the system. They're touched by all of those, and they touch all of those. So if you're going to counsel, start with the inner rings, start with the child. What are some specific things with that child, then move to the family, then move outward, and try to touch on the things that seem most important and where you can make a difference. Community influences, we talked about that. The other thing is to make diet a discussion, not a directive. We in our hospital-based outpatient clinic, we feel small victories are important. And so we may not get everything we want, but if we can reduce one risk factor, we feel like we've made a step in the right direction, and the family then can move to another one. Okay, provide alternatives. So instead of saying, Nancy Reagan, just say no, give alternatives and give mitigators, little pieces. I mentioned that several times. Incorporate diet and beverage choices with other anticipatory guidance, and think about recall frequency. Is it important to see this child? Now we do a lot more non-surgical management of caries with fluoride varnish and with silver diamine fluoride. There are reasons to bring children back other than 6-month recall. And again, if they have the wherewithal financially or with their coverage to be able to do that, and other circumstances in their life, it's important for the reinforcement. The proper approach may be not eliminating something, but minimizing. So, again, small victories. And then you may not accomplish this all within a 6-month recall period. You may end up having to do this over a period of time. The positive side is there's a multi-child family. You may see cascading effects on other children that you never thought would happen. So again, there's some opportunities there to do some good. Next slide. So what can we use in our diet counseling? I said it several times, sugar is still our enemy and an essential element of around which we counsel. Frequency is important, and I think I'll talk a little more about that in a minute. But you see pictures of piles of sugar cubes. I think I probably have one in here. And the amount of sugar is not as important as the frequency of exposure to teeth, and that is surprising. And what isn't surprising is if you have frequent exposures to sugar, you probably are taking in a lot of sugar, but frequency is still very important. Diet patterns are important. When you eat sugar, we still recommend eat sugar at mealtime, get it out of the way. Fluoride exposure is still essential, so you can't do nutritional counseling without talking about fluoride. And then a big area now, and I don't know if you have had a chance to read the most recent NIDCR statement on oral health in America and the challenges that are out there, but a big part of that relates to social determinants of health, things that we're talking about in the community, in the family, that affect health. And there's a lot of strength and resiliency in every population. And if we can piggyback on the ability of families to do things, we're going to be successful. So a social determinant of health does not have to be a negative thing if a family's overcome it. Their ability to overcome something suggests that they have a resiliency and an ability to try to make it even better. Next slide. Okay, just this is more informational. We talk about the preschooler. I'm not going to spend time on that diagram at the left. That's available from the federal government. If you just go to your browser and look for diet of preschoolers, you'll find this image of the things they're supposed to eat and and then on the far right of that diagram, what it really looks like in terms of what you can put in your hand. So, on the right-hand side, you can see we got a way to go. A quarter ate no vegetables and no fruit. French fries, not surprisingly, are the most commonly consumed vegetable in the preschool age group. I mean, it's sad to say because that's not great for heart or teeth. So anyway, sugary drinks, you could read that part of it. Snacks are almost a third of a diet, and most of those are things that stick to teeth. So, and then a quarter of calories in 2 to 3 year olds are from sweets and sugary drinks. And the whole purpose of me including this is just to show you what you're up against. That in the diet of the typical kid of this age period, you've got some challenges. Next slide. So here's some things, good and bad. The plus doesn't mean that it's necessarily good. It just means that it's above what is recommended. So it's not, I don't interpret that as a good thing, but 95% of the, above in the area of refined grains, 99% empty calories is percentage of kids who take that. Added sugars, 60%, sodium, 92%. And a lot of this is just because we eat so much processed food. On the other side, on the right-hand side, things that kids are not getting enough of or not enough kids are doing, fruits, vegetables, dark green vegetables. Kids don't like spinach, broccoli, stuff like that. Whole grains, and that's a choice. Whole grains are a choice that is a relatively easy one to make. And then dairy for a number of reasons. And this is NHANES data. This is all available to you if you want to look it up and go into more detail about how to take that information and try to address those within a population. Ask those questions. What are you eating? What's your child eating? Next slide. I want to talk a little bit about sugar sweetened beverages. And one of the things that confronts us in pediatric dentistry is beverage use, sleeping with a bottle, and that the new guidelines, the new beverage guidelines have really kind of been a gut punch for us in terms of the things that we were very comfortable in recommending. So if you look on the left-hand side of the slide, you shouldn't give kids flavored milk because of the sugar. Toddler formulas and toddler milks designed for toddlers, again, because of the sugar. Plant-based, a lot of people are into oat and nut-based drinks, a lot of sugar in there. A big one for me to realize was we would recommend kids have diet pop. And if they had to have something in a bottle to walk around with or right before bed, if there was absolutely no way the parent could come to take it away, we would say, give them some diet pop. Well, the caffeine can stay in a 3-year-old system for like 13 or 14 hours. And so some of the sleep problems that have been attributed to tooth decay or to other things, maybe we were generating. Obviously sugar sweetened beverages. And then the other one that is somewhat controversial, but I'm going to talk a little bit more about it later, is artificially sweetened beverages. That's a no-no now in the preschool population. So we've got to, when you take the caffeinated pop and the low, the sugar sweetened, the diet beverages away, I mean, that's really took a lot of what we would recommend before. So what are some things we can do? We can wean from bottle use. That's always a good idea. We can tell parents, don't be an example. Don't you walk around with a screw top bottle of sugar containing drink in your backpack or your purse or your pocket. We see that an awful lot. Use fluoridated water when you can. Make it a priority. If you're out walking or doing stuff, if you have to drink something, don't carry a bottle of it. Just stop, get something. You know, take a drink from a fountain, or just stop, and don't walk around with an open container. Make a point of stopping to take a drink. And at night, substitute attention from a parent for a bottle, or give them a toy, a favorite toy, instead of a bottle. And then if you have to put them to bed with a bottle with anything in it, slip it away when the child's asleep. Don't have them using it all the time. Those are things we still can do that maybe will be beneficial. Next slide. Okay, water came up an awful lot in the development of these guidelines. There's a lot of anti-fluoride sentiment in our country. It's our, this is a harbinger or an illustration of some of the political discomfort that we're experiencing as a country. And so fluoride can't be taken for granted as a part of diet and hydration, because people sometimes will not drink it because they don't want fluoride. So you look at the right-hand side, this is a bimodal characteristic. So when you don't make assumptions based on what people look like. Rich people don't drink community water, and poor people often don't drink community water. So remember Ruby Payne's diagram for different reasons. So don't make the assumption that based on someone's income, appearance, and other behaviors that they drink communal water with fluoride. Minorities, rightfully so, may be opposed to communal water. You know, we read about the lead pipes in many underserved communities, and then I mentioned Flint, Michigan, and the water contamination there. And now we're seeing military bases having fuel contaminate the water. So there's a lot of stuff going on you got to ask about. Or I mentioned the study in Utah about immigrants and what their drinking habits are, and the reasons they do it. And then realize that a bottle of water has no fluoride guarantee. If you live in a fluoridated community, there's some surety that you're going to get fluoride in your water, but bottled water has no fluoride guarantee in the sense that every bottle you take is going to have fluoride. I talked about the culture wars, the political aspects of this. That slide on the left was a sticker. I had my car washed in North Carolina back in April, sticking on the car wash. So there are fluoridation wars going on everywhere. And then, of course, as we know about fluoride, where you live and the piping, the presence of wells, all those things affect fluoride availability. We could talk for 2 hours on fluoride. Next slide. So, so for kids under 5, the preschoolers that we're focused on, put beverages into the context of the overall diet, apply the basic principles of beverage counseling, reduce sugar, no bottle at night, no sugar containing liquids in bottles or sippy cups, no liquids after brushing with fluoride toothpaste, and then drink fluoridated water when possible, preferably from the tap. If you need to drink juice, 100% juice, it doesn't have added sugars or shouldn't. If you need a walking drink, make it fluoridated water, and milk and 100% juice are really the best at meals and snacks. And these are all available in the guidelines for preschool kids in terms of beverage recommendations. So you can find that online. Next slide. So I'm going to go through this relatively quickly. There is a disparity in diet, and we can't overlook that. We really have to spend our time focusing on the family and their circumstances, because there are some things that they can't change, and there's some things maybe they can change. So we really have to spend time talking with them. Here's the slide on the table on the right, shows some of the characteristics of diet in preschool kids, and you can see on the left that children of color are very often disproportionately affected. So next slide. So the beverage guidelines are out there for preschool kids. They need to be tested over time. It's an expert generated list, so that has not, it's evidence-based, but it has not been tried in the real world. And we're not really sure how they can fit into life. So your counseling may be part of the natural experiment to see whether these beverage guidelines fit in. And there are some unknowns. For example, stevia, which is an artificial sweetener. It's a sugar substitute, but it's a natural compound. But there are still some concerns. I cited a couple articles here below, and you can read about it. We really don't know yet about stevia and its long-term effects, even though it's supposed to be a biological rather than a chemical. So again, there's a lot we still need to know. Next slide. So I won't belabor sugar anymore. You can see on the right-hand slide, there's still a tremendous amount of sugar and empty calories in our diets. Those are things that you can uncover both for oral and systemic health. So to go full circle, a lot of what we would do to counsel for sugar reduction really has a benefit on a child's life. The contribution over a lifetime to heart disease and diabetes and so on. So there's a lot we can do working with our colleagues in medicine to try to affect a reduction in sugar consumption. Next slide. I think this is the only point I would make here is, if you're going to do adequate counseling, really understand that sugar is in almost every food. If it's processed, it has sugar. And then the last item there is, it doesn't take much. There are some classic experiments back in the 1960s where they fed gerbils or ferrets or rats cellulose, essentially cardboard, with just a tiny bit less than 1% sucrose, and it generated dental caries. So any effort you can make or any accomplishment in reduction will ultimately benefit the child. Next slide. So, and realize there's an industry that is pushing sugar. It's really, really important to recognize that the obstacles to this can be very difficult to overcome. I mentioned Stephen's curve. That's a classic experiment where they took dental students and had them not brush their teeth for a day or two and fed them sucrose or sugar and had them rinse, and they had pH meters in their mouths, and the pH after a rinse of sugar liquid depressed the pH or the acidity in their mouth to the point that it would generate tooth decay, and it took about 20 minutes for it to get back to normal. So again, when you talk about frequency, every consumption, if a child doesn't have perfect hygiene and has plaque on their teeth, can potentially generate enough acid to cause caries. So just remember that, and it's everywhere. So you got a big job. Next slide. I think that might be it. Yep. So it's to kind of wrap it up here. I think I'm close to my time. I know I didn't give you a solution or an easy factor or easy system, but I hopefully gave you some ideas about things that you can do, or maybe not been doing, or maybe have been doing, and just needed the reinforcement to know that you've been going in the right direction. So that's it.
Thank you so much, Dr. C. That was a great presentation. A lot
Thank
of
you.
valuable information there.